Welcome back to another exciting episode of 60 Plus Uncensored. I'm your host, Seb Fry, and today's guest is Dr. Theodore Henderson, an MD and PhD in neurobiology whose work spans psychiatry, neurology, nuclear medicine, brain imaging, dementia, and traumatic brain injury. In our interview, Dr. Henderson kind of rocked my world because I've long been told that dementia is progressive and irreversible in 100% of cases. But Dr. Henderson is here to say that's not the case and explains how infrared laser treatments can go a long way to restoring cognitive function in those with dementia and traumatic brain injury. So without further ado, let's get into it. All right, today we're very excited to have Dr. Theodore Henderson on 60 Plus Uncensored. Now, for those of my audience who are not yet familiar with Dr. Henderson and what he's all about, would you mind giving us a little introduction to who you are and what you're all about?
Sure, I'd be happy to. So I'm both an MD and a PhD. My PhD was in neurobiology, so I was looking at how the brain organized itself and developed, which led me into things like growth factors and neuroplasticity. Fast forward a few years, I then was working in neuroimaging, looking at functional brain scans. And I got really tired of saying to a patient, well, your brain scan shows that you have a traumatic brain injury or that you've got early signs of dementia, but we don't have anything we can do for you. Sorry. I was approached by a colleague, Dr. Larry Maurice, who's since passed away, who said, hey, look, I'm working on this idea of using infrared light like they do at Harvard on mice, but using it on humans to treat traumatic brain injury. Will you do the neuroimaging with me? So when I stopped laughing, I said, infrared light can't do anything, can't get through the scalp and skull and reach the brain. He says, well, yeah, it can. And one of my associates, Jenny Faraday, pulled me aside and said, Doc, don't be a jerk. Look at his literature. It's all from Harvard. And sure enough, it was. And so Harvard had already shown, look, if we treat mice with infrared light, their brains heal from traumatic brain injury, from stroke. And so I said, okay, we're going to do this, but we're going to do it right. And I'll talk about that in a minute, but I just want to fast forward to, we started treating patients and they started getting better. In fact, in our clinic, every patient we have treated has seen improvement. Now, where it gets interesting is when we start to talk about things like dementia. And that unfolds into a 4-part story, which I can go into.
Well, yeah, I'd love to hear about all of that. And so, because I've been told that dementia is irreversible. I mean, like that to me has always been told, like this is like scientific fact. It's not theory. There's no cure for dementia. It's progressive and irreversible. And so what you're saying is that's not true?
That's exactly what I'm saying.
Really? So, okay. Well, maybe you could just take a step back and tell us how infrared light does in fact get through the skull and the scalp and all that to like actually reach into the brain. And like, is there a specific kind of like wavelength or just, can you like take us through that?
Absolutely. I'd be happy to. So let's get to the level of the cell first and then work our way back out to the scalp. Within the cell, there are little organelles called mitochondria, those little powerhouses of the cell. They make energy. And mitochondria do a couple of different things. Number one, they produce ATP energy, but they also put out signals. And those signals, little proteins, tell the chromosomes to turn on this protein or start that process or reduce inflammation, et cetera, et cetera. So certain wavelengths of infrared light can activate the mitochondria. I could go through all the science of that, but we won't. And once those mitochondria get activated, 2 things happen. Number one, the cells have more energy. So if you've got a cell that's sort of limping along, it's barely functioning, and it gets more energy, it will function better. It doesn't matter if we're talking about a brain cell or a lung cell. The second thing is the mitochondria start sending signals that reduce inflammation. So it doesn't matter, again, if we're talking about a brain cell where inflammation is a part of dementia, it's a part of Parkinson's disease, it's a part of depression. Or the lung cell, say in a long COVID patient. They can't walk up the stairs because they get winded, inflammation. Another thing that gets turned on, most importantly in the brain, are growth factors. The most important one is brain-derived neurotrophic factor, or BDNF for short. Now, BDNF is the driver of neuroplasticity in the adult brain. It's literally what I was doing my postdoc research on. And when I saw in those Harvard studies, it's turning on BDNF, I realized, oh my gosh, this is a gold mine. We've been trying to figure out how to turn on neuroplasticity in the human brain for 60 years. And here we have a way, naturally, painlessly, easily. But the problem is getting through the scalp and skull. So now let's zoom out. So I said to Dr. Maurice, I said, Larry, we're going to do this, but we got to do it right. So we need to go into the research lab and figure out how much energy it takes to get through the human scalp and skull and 3 centimeters into the brain and deliver the right amount of energy, not too much, not too little, without hurting the person or burning their head or setting their hair on fire or anything else like that that could go wrong, right? So we went into the lab and we started with sheep heads and then worked up to cadaver heads and then worked with actual living human tissue. Dr. Henderson's hand happens to be 25 millimeters thick. If I put an infrared light source here and a meter here, I can tell exactly how much light gets through 25 millimeters of skin, sinew, bone, muscle. And so with that kind of compilation of work, we published in 2015 this paper that really laid out how light penetrates to human tissue and how we could reach 3 centimeters into the brain. And what they were doing with mice was using half-watt LEDs. And you can go on the internet and you can find all sorts of infrared light devices that treat the brain that have half-watt LEDs on them. A half-watt LED penetrates less than a millimeter through human skin. It is not treating the brain, no matter how much they try to tell you it is. It's not treating the brain. And so these devices are out there, and people are paying thousands of dollars for a device that they stick on their head and say, oh my gosh, I'm treating my brain. Well, it's, number one, it doesn't get through the hair. Hair blocks infrared light, and it doesn't get more than a millimeter through the skin. So it certainly doesn't get all the way into the brain. So what we have is multi-watt infrared light. We're working in the 10 to 15 watt range, but we know how to do it safely, and we've worked that out, and we've been treating patients since 2013. Right?
Wow, so that's incredible. So I have so many questions. Well, let's start with neuroplasticity, because you mentioned that a couple of times now, and not everybody knows what that is. So what is neuroplasticity, and how is it important for reversing dementia, say?
Yeah, so that leads us right to where we want to be. Great question. I really appreciate that question. So neuroplasticity, we think about neurons as sort of, being sort of just sitting there, doing their thing, sending electrical signals through their body, and then when they get to the next, when they get to a synapse, the end of an axon, they send a chemical signal to the next neuron. And so those synapses, those connections, are very important. And in dementia, you get fewer and fewer and fewer synapses. And the little branches that pick up connections, called dendrites, the little part that looks like a tree on a neuron, they get fewer and fewer. You lose all those branches. It looks like a rose bush pruned in the winter rather than a big willow tree. When BDNF is released into the brain, it activates new synapse formation and new dendrite branches. And so you get new connections, you get new circuits. The cells get healthier, they function better. And so all of that leads to a reversal of the degenerative change that is going on in dementia. There's another piece, and that's the piece of toxins, which we'll talk about in a bit.
Okay, all right. So also, you mentioned that it goes 3 centimeters into the brain. Well, where does dementia show up in the brain? I would imagine the brain is yay thick, right? I mean, where does dementia happen in the brain? Does it only happen in the top part of the brain, or?
Well, so the dementia starts in the hippocampus, which is in the temporal lobes, about 2 centimeters in right there. And then it spreads along the inside aspect of the temporal lobes, anteriorly and posterior, front and back. And then it starts to progress up into the parietal cortex. So on a functional brain scan, what you see 7 years before a patient even has symptoms, 7 years, you'll see a dropout in the function of what's called the posterior cingulate gyrus, which is right up here, kind of towards the back of your head, just behind the center point. And that is a part of your brain that's incredibly active, and it's involved in all sorts of spatial awareness. And so when that starts to go, and then it spreads to the rest of the parietal cortex, so now you got temporal lobe, parietal cortex involvement, then you can't draw a clock and you get lost in your own neighborhood.
Okay, so when you do a brain scan, so you're saying that even before anyone has signs of dementia, like you could get a brain scan and it would tell you, oh, in 5 years you're going to start exhibiting. So does that mean that people should be like getting their brain scanned at like starting at age, 40 or 45 or something? Or
there's a lot of people who advocate for that approach. But interestingly, in the field of neurology and psychiatry, functional brain scans are looked at like, ew, and they don't want to have anything to do with them. The typical functional brain scan that I work with are called SPECT scans, S-P-E-C-T. And I published a paper in 2012, so a long time ago. And I predicted 2 things. I predicted one, and I didn't invent this prediction, but we're going to be at 8 times the number of people with dementia by 2025, and we blew past that number. We're actually higher than what was predicted. The second thing I predicted is all these amyloid buster drugs were going to fail. And sure enough, all the amyloid buster drugs did. So when you look at what we can do with functional brain scans, it would be logical to spend the money to do serial brain scans. What we're doing now, though, is because of, honestly, political pressures within the medical field, the imaging of the brain pivoted to PET scans, positron emission tomography scans. And so, lots of big pharmaceutical money was pumped into developing amyloid markers. So now if you go to your neurologist and say, look, I'm having some memory problems, they might send you for an amyloid PET scan. They come back and say, oh, well, there's no amyloid there, so you don't have dementia. Wrong. Amyloid scans are, binary. It's 0 or 1. If you're 1, you've got amyloid, that's evidence that you have Alzheimer's. If it's 0, you can still have dementia. You just have Lewy body dementia or frontal temporal dementia or a Parkinsonian-related dementia. There's half a dozen dementias that don't involve amyloid. And so the logic and the thinking and the way the medical field has gone on that issue, and I could do a whole hour talk on that, is I think, wrong-headed, simply put.
all right, so I've heard the word amyloid before, but a little hazy on what exactly an amyloid is. Could you elaborate on that?
Absolutely. So let's stay with just Alzheimer's for a moment because it's a clean model. So in Alzheimer's disease, the neurons start to make an abnormal protein, amyloid, and amyloid clumps together, and eventually it fills up the cell and kills the cell, and that gets released into the cytoplasm, the fluid around the cells, and that starts to poison other cells. So amyloid is a toxin, and it builds up. Now, here's the interesting thing. About 8 years ago, someone discovered that the brain has its own special toxin drainage system. It's called the glymphatic system. It's so spiderwebbery that we never saw it because by the time we got to a dead brain, it had collapsed, and so it was not able to be visualized until fairly recently. And what we now know about the glymphatic system is two very, very important things. Number one, it clears amyloid and other toxins, inflammatory toxins, for example. And it works best in deep sleep. So the clearance rate of amyloid in deep sleep is 4 to 5 times that of waking. Now, what happens when you get old? Or you get depressed, or you get dementia, or you get a traumatic brain injury, or you get Parkinson's? Your deep sleep goes down. And
Tell me about it.
I mean, it's like, and I hate to say this out loud, I'm 65. And, my best sleep is those 2 hours from 5 to 7 in the morning. The rest of the time, it's awful. But that's when I get my deep sleep. I can tell from, whichever electronic device I happen to use. And so that's when I know I'm clearing toxins. But all the rest of the night, I'm not doing anything. Here's where we're back to infrared light. Infrared light, certain wavelengths of infrared light, not the commonly used ones, these are higher wavelengths, actually activate the lymphatic system. And so one study was done in Germany which showed that this particular wavelength of light increased the clearance of amyloid from genetically altered mice. I would say transgenic mice, not transgender. The U.S. government is currently confused about those two terms, but it clears amyloid 4 times faster than the waking state. So now we're back to infrared light as a treatment for dementia. It reduces inflammation, clears toxins, turns on neuroplasticity. Okay? All of that sounds really good, but does it result in clinical improvement? That's the real question.
That is a question, and I want to ask you. I want to ask you that question. But before I do, you also mentioned earlier that these amyloid buster drugs don't work, and so why don't they work? I mean, like, if the problem is amyloid buildup, do they just don't decrease amyloids, or there's some other mechanism at work that's causing dementia?
Right. So right about 2011, 2012, when I wrote that paper, another doc had come out with sort of a graph that really showed sort of the way we need to think about this. So the very first insult that happens in the brain is a buildup of tau protein. And tau is this sort of very common toxic precipitant within the brain. And so, tau is related to traumatic brain injury. One single concussive hit, there's a formation of a little bit of tau with each one of those. So imagine a football player or a rugby player who's made their career getting clobbered. They have lots of tau, and that's where we get into the post-concussive syndromes that we talk about for athletes. But in the case of Alzheimer's, tau is the very first protein that begins to go awry. And then later, amyloid begins to build up. So busting amyloid the horse is out of the barn. You're closing the barn door after the horse is gone. And that's why they don't work. Now, the latest things that they have out there, and believe me, Eli Lilly is pumping it hard, is the amyloid infusion. So antibodies against amyloid. And they infuse them into your body, and they cross the blood-brain barrier, and they get into the brain. Supposedly they remove all the amyloid. Now, here's the problem. When you look at the studies on these patients, number one, some of them develop brain swelling, brain bleeds, strokes, death. But the ones who don't necessarily get any cognitive improvement. They clear the amyloid, but their thinking doesn't get much better. That's a very key difference.
Right. Okay. So if you had to describe like dementia, is it just like the brain is like wither? Like, I've heard that people have dementia, like their brains shrink because their actual brains, their matter is like shrinking in, and like where does it go? And like, will infrared actually like cause the brain to like regrow and increase in size, or?
Yeah, Fascinating question. I can't say that this is happening in the human brain yet. But what I can tell you is that in animal studies, whether it's stroke or traumatic brain injury, and they've done a little bit with dementia mice, which are, again, transgenic mice that have altered genes, so they express more amyloid, et cetera, et cetera. And they've just used mice that they let sit around for a year and a half so that they're aged, and then they treat them. And what they've shown is increased BDNF, so increased neuroplasticity, which drives more synapses, more dendrites, and it actually converts stem cells, which we have in our brains, into actual neurons. Now, how often does a stem cell get converted into neuron and crawl up into the hippocampus and find its place and get a circuit? We don't have data on that. But it does activate stem cells, and it has been shown to actually lead to an enlargement of the tissue. So in the case of just traumatic brain injury, I frequently show a slide at scientific presentations of mice that were given a brain injury. They're whacked in the head, 100 mice whacked in the head exactly the same way, and then half were treated with infrared light. And the lesion is much, much smaller. It's like 20% the size of the lesion in the untreated mice. So clearly brain growth and brain repair has occurred. So in the case of dementia, obviously, if you have someone who is getting, a 12 or a 10 on the Montreal Cognitive Assessment, the MoCA, they're not going to come back to a 30. But, if you've got someone who's, 13 or above, we've seen really remarkable improvements.
And 30 is the best, or what is 30?
Yeah, 30 out of 30 is a perfect score. That means you can actually identify that an elephant's an elephant and a giraffe is a giraffe. And like nobody's heard about these tests lately.
I've heard about these tests lately. So are they hard to pass, or are they easy to pass?
They're incredibly easy to pass. I mean, I administer the Montreal Cognitive Assessment every day. I mean, you have to remember 5 items for about 5 minutes, and I intentionally try to confuse you. But other than that,
right.
Can you name 12 items that begin with the letter F?
Right. Well, I probably could do that, I think. So, okay. All right. So, so you also mentioned that you said that there's been an 8-time increase in dementia. Did I hear that correctly?
Yes. From, if we go back and look at where the numbers were predicted to go from 2012 to now. And this has been known. I mean, I was being hammered with this in medical school, is that we are on a very dangerous trajectory. In part because the baby boomers are aging, and the post-boom kids are aging, and we also have not found a cure. So these people get the illness, and then they just become one more number in a growing number of people with dementia.
So why? I mean, 8 times, that's a gigantic, I mean, like cancer is not up by 8 times. Why is dementia up by 8 times? 8 times since when? Since 1950 or 1900, or what's the baseline?
Yeah, the baseline was around 2010. So,
okay.
So I wrote the paper then. So the 2010 numbers have just grown astronomically.
Why? And that's a very short period of time.
Well, again, I think it's, the aging of the population and the fact that people are living longer. We have more 90-year-olds in the United States than we ever have had. And, the fact that we don't have a treatment.
Right. Okay. So it's not necessarily like an environmental thing or, exposure to toxins or is it inflammation? Our bodies are rife with inflammation now because of all the, I'm told just hyper-processed foods to a large extent and other airborne toxins and stuff in the water. Our bodies are trying to fight off this onslaught of toxicity that we're exposed to all the time. And that's what I understand a lot of that inflammation comes from. And inflammation of the brain, you're saying, is a key driver of dementia. Is that correct?
Correct. And a lot of other disorders. So inflammation,
right.
In the inflammatory process, that's what kills cells in Parkinson's. In depression and in PTSD, the hippocampus gets smaller. The frontal cortex gets smaller. And when you treat depression, even with medications, Prozac, if you get lucky and, Mars is in retrograde in Capricorn, then you might get a response from Prozac, runs about 12%. And what actually happens is that there's neuroplasticity and the cortex gets bigger. It's not about SSRIs, and it's not about serotonin. Serotonin has nothing to do with depression. That's a whole nother lecture. But let's stay with inflammation for just a sec, and this idea of toxins. So what is causing dementia? What is causing Alzheimer's? So one, there's a gene, and that gene it leads to either you're successfully able to cut that protein so you don't get amyloid, or you're not able to do that and you accumulate amyloid. So that's one piece, that genetic factor. We can't take that away. Number two, are you sitting down?
Yes, I'm sitting down.
Okay, all your viewers are sitting down because this one's going to blow your mind.
Okay.
There's very clear evidence, and this is the work of Ruth Ozaki out of England. She deserves a Nobel Prize. She has shown systematically over the years that herpes 1, the cold sore virus, causes Alzheimer's disease. Now I'm going to give absolutely mind-blowing, right? She's done autopsy, she looked at brains of people with Alzheimer's and consistently found the herpes 1 gene in the brain. She's done brain cell cultures where she exposes them to herpes 1, and sure enough, they develop all the signs of Alzheimer's disease. She's made transgenic mice that she then infects with herpes 1, and they develop Alzheimer's at an accelerated rate. But here's the mic drop experiment. I'm going to give you this. This is so cool. And this was done here in the U.S. at Tufts. They took baby foreskin and took out the stem cells. So baby skin is loaded with stem cells. So now you got a whole bunch of baby stem cells. They're newborn. You can grow them up. So you got a bunch of baby stem cells. You convert them to neurons by exposing them to things like BDNF and other growth factors. They'll turn into little baby neurons. If you give them this little spongy thing, they'll crawl up on the spongy thing and make synapses and start to fire circuits. They'll be signaling each other. Essentially, you have a brain in a dish. It's a baby brain. It's a week old. If you then dump herpes 1 virus into that petri dish, within weeks, days even, the neurons develop Alzheimer's disease. All the pathology of Alzheimer's disease is right there. That is, boom, a mic drop experiment. Just mind-blowing.
Wow. So how did she make that connection? I mean, is it just is it from research essentially? She just knows the pattern, or was there something about the herpes that made her suspect that was a key trigger for Alzheimer's?
That's a really good question. I'd have to ask Ruth.
Well, that's pretty far out there, right? I mean, who would think that a herpes sore would be a key driver for? So, what does she suggest that be done about this? I mean, is there any kind of actionable insights that she takes away from that? If you have a cold sore, should you immediately get it frozen off or something like that, or what?
Yeah, it's a really important question. But just a little bit more on Ruth. She's like one of these. She has taken so many slings and arrows. They wouldn't publish her research. They wouldn't give her research grants. Oh, herpes can't have anything to do with Alzheimer's. We're too smart. We're neurologists. We know everything. And sorry, I started writing about her in Psychiatry Advisor. Back in probably 2013, 2014. And around about 2015, a whole bunch of docs wrote to the Alzheimer's Association. I wasn't one of them. So about 100 and some odd signatures, and basically sent this open letter to the Alzheimer's Association saying, what the heck is wrong with you people? Look at her research. It's good research. It's solid. She is meticulous. So finally, that started to change the tide so that people would even talk about the possibility of herpes 1 having a role in Alzheimer's. Now, I want to clarify, Ruth believes, and she, to this day, she believes that it only affects people who have both of the ApoE4 genes, that gene that creates the abnormal amyloid. I don't think that's true. I think herpes 1 can do it regardless, and the proof is in that stem cell study. they didn't do genetics on those foreskin samples. They don't know if they happen to get foreskins from only babies who were ApoE4 double positive. They don't know. So in my opinion, the chances are extremely good, statistically speaking, that they had a whole mixed population. And herpes 1 still caused Alzheimer's in these newborn neurons. That raises a really important second question, getting back to inflammation. And I'll wrap this all up, don't worry. Why, if just being exposed to herpes 1 is sufficient to cause baby neurons to become Alzheimer's neurons, why is that not the case in humans? What are the protective factors that prevent some people from developing dementia? Because not every person who has Alzheimer's is herpes 1 positive. But Dale Bredesen, who's an expert on dementia, and he wrote the book, The End of Alzheimer's, totally cool. And it's really based on changing diet. And so he really speaks to the issue of how diet affects inflammation, affects the cell's ability to function and fight back against these insults. But he makes this point. He says there's dirty Alzheimer's. And what's dirty Alzheimer's? It's herpes 1 positive Alzheimer's. And the other thing he says in the introduction of his book is one of the ways to treat the brain is to pump energy into it. Oh, I know how to do that. So Dale Bredesen's work, he's a brilliant guy, and he has clinics all over the world now that coach people into these healthy diets that reduce insulin resistance and lead to anti-inflammatory, a reduced inflammatory state in the brain, leading to, the reversal of dementia symptoms. Okay? And
Wow.
I can give you an example of that, where I put all of that together in a patient.
Well, I do want to hear about that for sure, but now we're talking about diet and inflammation, which is really interesting to me. So, I mean, I'm always told, like, hey, it's meat, right? Meat causes inflammation, right? Don't eat meat. So is that what I'm sorry, Breslin, you said it was his name?
Dale Bredesen, Bredesen. Mm-hmm.
Who wrote that about changing diet to end Alzheimer's. So yeah. What does he recommend in that book? What should your diet be?
It should be meat and vegetables.
Really?
No carbs.
No carbs.
Yeah. And let me explain why. So what he looks at is what's called the insulin resistance. And insulin resistance is a derived score. It's based on a number of measures about how your blood levels are and your insulin levels are, et cetera, et cetera. If your neurons have a high insulin resistance, that is, they don't respond to insulin, your brain gets a burst of insulin and the neurons go, and don't respond to it, that's bad. Because neurons run on glucose. They can't eat anything else. They must have glucose. They can't.
What about ketones?
Anything.
I thought they like ketones.
Well, if you want to run anaerobic through cytoplasmic metabolism and have a buildup of lactic acid, you go for it. But
okay.
if you want
is that bad?
Well, okay, when you exercise and you overdo it and the next day your muscles hurt like the dickens, that's a buildup of lactic acid, and that's due to going anaerobic in your muscles. So imagine that in your brain.
Okay, all right.
Yeah. So his point is that, number one, humans aren't designed to eat carbs. We just started, growing crops about 50,000 years ago. So we have Neanderthal metabolism. Our metabolism has not changed in a million years. So we've not caught up to this whole thing of eating lettuce, iceberg lettuce, or eating wheat or oats. Number one, iceberg lettuce, we don't metabolize it. it's just roughage. But wheat and corn to a lesser extent, but wheat and oats, they lead to a higher insulin resistance. And so what he advocates is basically a Mediterranean diet. So fish and meat and vegetables and very little carbs, And I would follow it religiously, except there's a whole thing that no wine. It's like, no wine. Can't do it.
Hey now. That's crazy talk. So no carbs, right? So, but
Really
carbs are
yeah.
everywhere. Carbs are everywhere. Like root vegetables are loaded with carbs, right? Beans are loaded with carbs, right? So is he suggesting that basically it'd be like leafy green vegetables, essentially no root vegetables? Is that?
Well, and I don't want to. I'm not qualified to be able to fully articulate Bredeson's diet and protocol. So I'm gonna, just let's stay with the Mediterranean diet
Okay.
with some modifications. But the complex carbs are much better for you than simple carbs. Sweet potatoes are better than russet potatoes.
Right.
And
Yeah.
we'll leave it
So
at that.
I think that's a good way to simplify that whole thing, right? I mean, simple carbs bad, complex carbs okay in moderation, and whole foods, high fiber, stick with that. And that's the thing you hear time and time again. And I right now am not eating meat. I'm eating fish right now because I'm trying to reduce my inflammation because. Well, it's like a lifelong thing that I'm trying to do now. I've been trying to do that for the past, several years. So I really want to I'm actually going to the Mediterranean like a couple of days from now. So
Look at you.
I know I'm going to have a lot of Mediterranean food while I'm over there. So I'm going to check out that book, though. That's really important for me, I think, and I think for everybody to read that. You mentioned that you have the case study of somebody that you had them put on that diet, and also we're doing IR therapy. Can you tell us about that?
Sure. Yeah. So let's frame this a little bit. So the use of multi-watt infrared light. So we're getting through the scalp and skull and into the brain. And we have a laser that has the capacity to deliver 4 wavelengths, but 3 wavelengths are relevant here. One is in the 800 range, which activates the mitochondria. The next is in the 1000 range, 900 to 1000, which activates the mitochondria and reduces inflammation. And then we have another wavelength that does two jobs, and that's 1064 nanometer light. 1064 nanometer light was shown by Gonzalez Lima, who's down in Texas, to increase cognitive function. Whether you take a bunch of college volunteers and you do a IQ test and you hit them with infrared light, and then you do an IQ test again, they do better. And with people with mild cognitive impairment, they do better. And people, they measured alpha wave activity in the brain using QEEGs, and they showed alpha waves improve at 1064 nanometer light. Point 1. Point 2 is that 1064 nanometer light is right on the edge, just barely on the edge of the spectrum that activates that toxin clearance system, the glymphatic system we were talking about earlier. So here I'm treating people with things that turn on neuroplasticity, reduce inflammation, clear toxins, and improve frontal lobe function, all in one treatment. Okay? So we started treating patients, and I'll give you a couple of different examples of just what has gone on here in the past month. Woman came out here from Buffalo, New York. Her Montreal Cognitive Assessment was 16. That puts her in the moderately demented range. Okay, and she lives in a facility in Buffalo. Her son brought her out, delightful lady, and we also measured with the QEEG her P300, and just very briefly, that's a sort of a response to a novel signal, and the P300 gets smaller and gets later and later. It should be 300 milliseconds after the signal. Hers was like 420. So way late. After 10 treatments with multi-watt infrared light, her P300 was now at 370. So it had come down, and it had gone from like 4 microvolts to 12 microvolts, and her performance on the MoCA went from 16 to like 19. So she completed 20 treatments. Her MoCA came up again to about 22, 23, right in that range, so improved dramatically from where she started. And her P300 came into the normal range. So that's just one example of someone I just treated with a few weeks ago with just multi-watt infrared light. Now, of course, since I think Ruth Izaki is a genius, I tested her for herpes 1. She's positive. And she has one amyloid one amyloid gene that's dangerous. So we sat down, and I said, okay, you're positive for herpes 1. We're going to put you on Valtrex, valacyclovir, an antiviral that's specific for the herpes virus. And we're going to talk about Dale Bredesen's book, and I want you to go find a Bredesen clinic there in Buffalo and get started with treatment with that. And we're going to sweeten the pot. I'm going to send you home with instructions to buy a low-power infrared light device. Remember I said they don't work?
Right.
They work through the skin, and so they're a good supplement. We could have a whole talk about that. And so she's gone off to Buffalo, and I checked in with her 3 weeks after she's been back, and she's doing okay, and she's remembering things better, and her son is shaking his head sitting next to her. So that's just an example of this is every day in the clinic. Now let me give you an example of a patient that we treated 2.5 years ago. Okay, remember the first thing you said to me was dementia is progressive. There's no reversing it. People get worse and worse.
That's what they tell me.
And then they die. Then they die.
Yes, that's what they tell me.
Okay. Her Montreal Cognitive Assessment score was 13. Her P300 was only a little bit delayed, not horrible. So we're just going to focus on the MoCA. And she had 10 treatments, and her MoCA had gone from 13 to 16. She had 10 more treatments, and her MoCA came up to 22. So we're now back in, just mild cognitive impairment range. And she was able to function better, and she could go for walks in her neighborhood and not get lost, and she was able to do more things, and she could have conversations. And she, of course, was herpes 1 positive, and I started her on Valtrex. And I handed the family a copy. I don't know how many copies of this book I've gone through. I handed them the copy of the guidebook of the Dale Bredesen diet and sent them home. And every 3 months we have an appointment. And so here we are 2 years out. We repeated the Montreal Cognitive Assessment. It was 22. It's now 23. And she's had no further infrared light treatments. She's not gone and gotten amyloid buster drugs. She's, I've got her on an acetylcholinesterase inhibitor, and I've got her on Namenda, which is an NMDA receptor antagonist. So I'm doing, sort of standard pharmacology, but, I don't think that that's the source of her improvement. I think, she improved over 8 weeks of multi-watt infrared light from a 13 to a 22. And she's held it for 2.5 years.
Yeah, that's really impressive. So you said she tested positive for herpes 1. So, like a lot of people have had cold sores. I'm sure I have had one. So, but that virus stays in your body. Should everybody get tested for herpes 1 and start taking Valtrex if they test positive?
Well, in a very short answer, yes, absolutely.
Really? Okay.
But here's the problem. I'm an honest fellow. So a study was done in New York, and they got a bunch of people who had mild cognitive impairment and were herpes 1 positive, and they put half of them on Valtrex and half of them on placebo. And they just published a study about 3 months ago. Well, according to them, the people who were on Valtrex got worse faster.
Really?
Than the people who were on placebo. And when that study came out, I looked at it and I read it and I studied the statistics and I emailed Ruth and Izaki and said, what the heck is that about? Because that is not my experience. I use antivirals quite a bit because part of the reason I got to know Ruth Izaki is I was working in chronic fatigue syndrome, which is caused by herpes viruses, such as Epstein-Barr, herpes 4, or herpes 6, sometimes herpes 5, cytomegalovirus. So her response was, I don't know, it's not my experience either. So there is this study out there that says, oh no, Valtrex is a waste of time, but I tell you, I take 1,000 milligrams twice a day because I'm herpes 1 positive, I'm 65, I don't want to lose my brain. Simple as
Right.
that.
Well, you seem pretty sharp. So, but do you have to take Valtrex forever? I mean, you're taking it all the time. I mean, it's like a daily thing you have to take. Just Valtrex, Valtrex.
Yeah.
Really?
Yeah.
And so there's
you can't kill off the herpes virus.
right. Can you not kill off any virus? It's just impossible.
Exactly.
Like if you,
Viruses are not alive.
right, they're not alive, and there's no way to. Well, because like HIV can now be really, I mean, very successfully suppressed in the body, right?
Yes.
Right. I mean, to where it's undetectable. Is that not possible with other viruses, or is that not?
It is. And so, like in my work with chronic fatigue syndrome, I have patients who, they're housebound or even bedbound, and they go back to normal function. Now, some of them, after, a couple of years of functioning normally, I'll say, okay, let's see what happens when we stop the Valtrex. Now, sometimes it's great. They're fine. They're going on 100-mile hikes and living their life and hiking the 14ers here in Denver. And it's like, okay, hasta la vista. But at least half of them begin to lose ground. And so we put them back on the antiviral and they recover. And we'll do that 1, 2, 3 times. And, I have several patients who just said, screw it, doc, I'm going to stay on the Valtrex. And,
right.
For me, I have the confidence of having treated people for 15 years with this medication. So I'm perfectly comfortable taking Valtrex twice a day, 1,000 milligrams twice a day, for the rest of my life.
Right. Yeah, seems like a smart thing to do given the research that you have been citing here. So you mentioned that there are these genes which cause amyloid buildup, and like, what about I don't know. This is maybe science fiction. I'm probably totally wrong here, but CRISPR is like a gene editing system, right? Is it not possible now to edit your genes as you're already alive and have that fixed essentially, or no?
Yeah.
That's not yet possible.
It's still within the realm of extreme possibility, to quote Fox Mulder. But we're not quite there yet.
Fox Mulder. Right, but it is possible. 'Cause my kid is 15, and he wants to be like a biohacker, right? I mean, he wants to be able to edit out these kind of chronic illnesses, or I mean, he's 15, right? Or actually, I guess he's 14 right now, and that's what he says he wants to do. So that might be something in the future, but just not yet today. And today we have to rather treat the treat the symptoms rather than the causes. Okay, so you mentioned that people are taking these 20 sessions, right? So how long does a session last, and what's the average number of sessions that a person takes to get a 40 or 50% improvement in their MoCA score?
Yeah, great question. Thanks for asking. So a typical treatment lasts about 30 minutes. This is hand delivered. And we have a hand device that is delivering infrared light via a laser. So we're literally lasering your brain. And we're treating the frontal cortex and the temporal lobe, getting back here where the hippocampus is, et cetera. And then, so that lasts about 30 minutes. And that varies slightly depending on what wavelength I set and what frequency of on-off I set, pulsing. But overall, 30 minutes. And typically we'll do a protocol of 3 treatments for the first few weeks, and then we'll go to 2 treatments. But just in terms of logistics for a lot of people, it's easier if we do 2 times a week. So in fact, we have a clinical trial that just got approved by the IRB. In other words, it's just got approved as being an ethical study that we can do looking at dementia. So we'll be recruiting subjects here pretty soon, who are aged and have some memory difficulty, and if we'll rule out anybody who has depression, because depression can cause memory difficulty. But these patients will come in, they'll get a 30-minute treatment 2 times a week for a total of 20 treatments, and then we'll do MoCA at the beginning, MoCA at the end. We'll do the QEEG at the beginning, QEEG at the end. And we'll do some psychometric testing, some memory testing before and after. And so that study will be starting probably August, but we'll start recruiting patients here in the next month or so. And so again, the question is, how many treatments does someone really need? And here's what I do in clinical practice. We do the baseline testing, and then we do 10 treatments and we repeat it. Now, I've had a patient with PTSD where, after 6 treatments, he said, "Holy Toledo, I feel so much better. The jets fly over and I don't cower." Literally, and I've sat in his backyard and the jets had flown over like they do here in Colorado, and he just sits there. He's fine. But it used to be he was in the basement crying. 6 treatments. But at 10 treatments, we repeat those measures so that we can see how you're doing, and then we do it another 10 and we repeat the measure. Now, when we do the analysis and we say, well, okay, look, your P300 is still way out of range, or your alpha waves are this, or it's clear your brain is still reorganizing. This is probably the key thing that I'm seeing now. I'll say, look, another 10 treatments, that will settle down. And sure enough, they do another 10 treatments, so 30 treatments total. That reorganization settles down, their P300 comes into range, the alpha theta balance in the brain, all this kind of metrics that we're looking at, they all come together. And the patient feels great.
Right. Okay. That's amazing. So you said hand delivered. So there's somebody with a laser pointer that's basically is it you or is it a technician or who actually does this?
Both. So you could think of a it's not a mouse, but think of a mouse. There we go. And this is putting out a little bit of laser light, but the aperture is actually bigger. It's about the size of a silver dollar, and the amount of energy it's putting out is zero point 0.1, maybe 0.05 watts. But we're putting out 10 to 13 watts. So it's 10 to 15 in some cases watts that we're putting out. So it's a lot of energy. You have to know how to do that in a way that doesn't hurt the patient. This is not something that people can do at home. You have to be trained. And so all my technologists are trained very carefully. They had to treat me 5 times before they get to treat a human being, which assumes I'm not a human being.
So in the future, do you see there being special built? Because in sci-fi, they reprogram someone's brain, they put him inside this helmet with lasers shooting in at him. Do you really see something like that coming where it's just an actual medical device that's sort of standard and available around the world, or is this something that's always going to be hand delivered, hand tuned like that?
Yeah. Since we first started doing this, Dr. Maurice and I were sort of conceptualizing how that might work. But I'm always haunted by the scene out of Logan's Run, where the computerized device suddenly goes crazy and it's shooting lasers everywhere and frying people left and right. So, I don't think we're quite at that point, and I wouldn't want anybody to rush to that kind of treatment model.
Right. So for right now, who does this besides you? Is this really frontier work that you're basically right there and everyone else is behind you, or is this can I go to Harvard? Can I go to Stanford? Where is this available?
Yeah. It's a very interesting question, and you're touching on one of the big dichotomies in the field. So. Right now, most of the practitioners are using low-watt infrared light. They're using half-a-watt devices. I won't name any names, but Harvard's done some studies with this. Boston University's done some studies. Stanford has taken that 1064 nanometer light, I think it's Stanford, from Gonzalez Lima and put it into some helmet that you stick on your head over top of your hair, let me remind you, and say they're treating the brain. And they get some result because the skin does creates some sort of factor that leads to indirect effects throughout the body. That's a whole nother lecture, but I published a review article in 2024 in Frontiers in Neurology, in which I criticized the field of sort of leading people astray. And I said, we're really in danger here of being labeled charlatans, because you're claiming you're treating the brain with a half-watt LED device, which doesn't get to the brain. You're treating the skin. And we need to be honest about that. And I proposed a whole bunch of studies that would prove that. Now, what I'm doing with multi-watt infrared light, I've shown that that gets through the scalp and skull. And a study just came out of a collaboration between the US and China, where they use computer models to look at infrared light penetration through the human scalp and skull and into the brain. And what they come back with, oh, well, gosh, you really need to have like 10 watts or so to be able to treat the brain. So they basically, validated all the work that we did by hand in actual tissue back in 2013-14. So where can you get multi-watt infrared light therapy? That would be Denver, Colorado.
Denver,
now.
Colorado.
Yeah.
I'm going to Denver, Colorado in September for the Society of Certified Senior Advisors conference. Maybe you should pop on down. And they already have their speaker slot all filled up, but I know that a lot of my colleagues in the society would be very interested to hear about this. So, so amyloid buildup, genetic. A lot of times I've heard that, like, if your parents have Alzheimer's or whatever, you're at much greater likelihood of you yourself getting Alzheimer's. And so a lot of people are freaked out about that. So what should somebody do if they're 40, or I'm not sure at what point, but you're getting older, middle age? Should you get a scan? Should you get what do you call it? You call it a SPECT scan? Are those done everywhere too, or do you need to go to Denver for that too?
Well, we get into an interesting thing here, I'm looking for people who would love to be part of a class action suit on this. Here's the deal in Colorado. So you can get a SPECT scan in Colorado. Every hospital has a SPECT scanner.
Every hospital, okay. Stanford.
Every hospital has one.
Right.
They're routine.
Right.
But in Colorado, the radiologists, one group of radiologists, one company of radiologists, have taken over the authorized user position in all the hospitals. The authorized user is the person who signs off on whether someone can get a radioactive substance. A SPECT scan is a radioactive study, so is a PET scan. And they decided no SPECT scans. Initially, they said, we're not doing SPECT scans for traumatic brain injury anymore. And so I sent them a dementia patient. They refused to do the SPECT scan for dementia. Then I sent them a stroke patient. They refused to do the SPECT scan for stroke. And I shopped around to all the other hospitals and I got the same response, because then I said, okay, well, who's the authorized user? Oh, it's Dr. Such and Such. And I look at the list of people on that company, and there's Dr. Such and Such. And so basically in Colorado, you can't get a SPECT scan. So let's talk about this 40-year-old. I think I remember 40. Number one, know your amyloid genetics. And so go do that study. Go do that genetic test. Now, for a lot of years, doctors were reluctant to do that, because since there's no treatment, it's sort of a death sentence. Oh yeah, you're going to get Alzheimer's. You're going to be foobarred by the time you're 60. And so they ethically didn't feel like they should do that. But we're at the point where maybe these infusions, and Eli Lilly would love to have you go get 10 infusions at $20,000 a pop and risk death and stroke and brain edema. But there are treatments now. So number one, know your genetics. Number two, pay attention to that dietary stuff. Number three, I would test for herpes 1. If you're positive, start dealing with that. And number four, get a scan. Now, if you get an amyloid scan, I've already talked about this, it tells you if it's positive, you have amyloid, you're at risk for Alzheimer's. If it's negative, it doesn't tell you butkus, because there's a lot of other forms of dementia.
Right. Yeah, sure.
Okay. And that's the part that they forget about. Now, SPECT scans, and I published this in 2012, can differentiate frontal temporal dementia from Alzheimer's, from Lewy body dementia, from temporal variant only dementia, from the Parkinson's dementias. So that data, that science exists, but neurology and nuclear medicine are sort of pushing that away. But
Okay.
you get a scan. Now, and then how often do you repeat a scan? I would say probably at this point in our level of technology, 40, 45, 50, 55, and then 60, you start to go more rapidly, more frequently, I should say. So, and again, biohacking is a thing. Your son wants to be a biohacker, and there are great people doing work in biohacking. Kristen Willemeyer, for example, out there in California. Kristen's a dear friend, and she has written a couple of great books on this. And there are ways of improving cognitive function. Daniel Lehman wrote the book, The End of Mental Illness. And Daniel and I have published research papers together on neuroimaging, and he's talking about how you can, again, change your lifestyle. Again, bless Daniel's heart, one of his first rules is no alcohol, which is like, what, no wine? So it's hard for me.
Right. So, well, we have learned so much here today, and I mean, if you are somebody who has like dementia or mild cognitive impairment, or you have a loved one who is, are you accepting new patients, or how can people get helped by you?
Yeah, absolutely, absolutely. So let me just put this in perspective. Years ago, I was in Paris with my wife and my youngest daughter, and I discovered a bar that had knew how to make Vespers correctly. And I don't know if you know Vesper, but James Bond, look it up. And so they were out having dessert and shopping, and they came back, and I'd had a few Vespers. And so I sat down and explained to my poor 12-year-old daughter why what I was doing was so important, and how if we could get this to the world, we would save millions of people's lives. And that is truly my belief, and that's truly my passion, is that I want to heal people. I'd love it if there was a line out the door, because that means I'm helping people. I'm helping more people. So absolutely, I'm accepting new patients. If you go to healmybrain.info, healmybrain.info, that's our website. It's the company's Neuroluminance, but who can say that? And and you can learn about it, and you can see some examples of these patients and their improvement in their function. I mean, people who couldn't draw a clock can now draw a clock. People who couldn't draw a cube can now draw a cube. It's so gratifying to see these patients get better and to regain joy in their life. I want people to enjoy their lives, not just drag their asses through it. Excuse my French.
Yeah, exactly. So, so someone can go to healmybrain.info and sign up for like an evaluation. They have to fly to Denver to meet with you. Is that how that works? And then if they're a good candidate?
We're in the post-COVID technological age. You and I aren't sitting in the same room, so I do my evaluations virtually. For example, I'm doing an evaluation next week on a gentleman in Bangladesh. And he's probably going to fly out here. But the treatments are hands-on, so you got to kind of plan to come out here to Denver for a period of time. Now, here's the important thing. This is very important logistically. I'm a real-world guy. I mow my own lawn. Well, I let it die and go brown, but because there's a drought. But I used to mow my own lawn, and so the pragmatics of coming to Denver and staying for 9 weeks to get a series of 20 treatments, that's daunting. So here's the reality. So looking at the patients with traumatic brain injury and stroke and whatever that I've treated over the years, we've been doing this, since 2013, 14. They can come out, from Florida or Toronto or wherever, and they can do, 6, 8, 9 treatments, fly back home for a month, take care of business, fly back. to a person, every single one of them says, "Doc, this is weird. I got better while I was at home." So I want to make sure that people understand what we're doing here. We are turning on neuroplasticity, and it keeps rolling even when the light's turned off. And so the brain is repairing itself in between treatments. You come out, do 10 treatments, go home for a month, come back. It doesn't hurt the process.
Right on. All right, very good. Well, this is incredibly encouraging because you've just sort of like turned my whole perception upside down of the treatability of dementia, and we're hearing so much about how infrared light can heal the body, like as you say, through the skin. And yeah, I mean, I've really have only heard about these half-watt lasers, essentially, which because they're like, I went to an assisted living community the other day. They actually have like an infrared room now, right, where you can book time in it, and they have a bed and like the helmet and all that stuff, right? So I mean, it's gone mainstream, but what you're talking about is really truly medical grade. It's several levels ahead of that. So that's
Correct.
very exciting times. And I see I have some more reading to do, and I really appreciate you taking the time to share all of this with our listeners and our viewers here on 60 Plus Uncensored. So again, if people want to get a hold of you, the best way is just to go to healmybrain.info, and there's like a book a consultation link on there somewhere. Is that correct?
Correct. Yeah.
All right, terrific. Well, Dr. Henderson, thank you so much for spending some time with me here today. I really do appreciate it. I tremendously enjoyed our conversation, and I will catch you on the flip side.
Absolutely. Thank you so much for having me.
All right, that's a wrap for this episode of 60 Plus Uncensored. Huge thanks to Dr. Theodore Henderson for setting the tone with such honesty and insight. Oh, hey, if you like this episode, do me a favor, do Dr. Henderson a favor, hit that subscribe button, leave a review, and share it with someone you know who needs to hear it. Oh, and by the way, if you know someone out there over 60 who's still doing big things like Dr. Henderson, living boldly, working with purpose, or aging on their own terms, I would love to hear from you. Reach out at team60plus.com or join the conversation at 60 Plus Living on Facebook. I'm Seb Fry, and this is 60 Plus Uncensored, because as we're learning, life after 60 isn't the end, it's just getting good.
Subscribe now.